to explain what's endovascular, everybody knows what vascular surgery is. You take a knife and cut somebody. Well, about 25 years ago, the same way that general surgeons stop cutting for everything and they use endoscopic surgeries, they basically enter the body with a special scope and they do the surgery through a tiny little hole. The vascular surgeons said, well, why don't we do the same? So instead of doing these bypasses where you cut open the body and you have this major surgery and a lot of blood, we put a tiny little hole in an artery, and through that, you play a video game. You basically go to the target pathology, to the target where you have the disease, and you treat that using all kinds of technology, including lasers, balloons, stents, anything you need to do to get the blood flow going. Okay, so that's endovascular. What I wanted to tell you about, since it's imaging in medicine, about what's the status of 3D imaging at the present time, then about a new company which is coming out really at the beginning of coming out on the market, which uses the artificial intelligence to help us do this vascular surgery much more efficient and much more easy. Then about another company which is showing us how to treat stroke, aortic disease, and pulmonary embolus. And I'll explain a little bit what it is, each one of them. But how do you get to treat them fast? Because these are emergencies. When people arrive with this kind of disease, time is essential. And then a last one, it's a company which takes the data from all you do, general surgery, gynecology, urology, take the data from this scoping you do during the procedure and process it also using artificial intelligence, and what's the advantage and what do you do it for. So, this is my membership in several societies, and I have no conflict of interest. So, what is the present state of this kind of disease? This is aorta, which is a main blood pipe going from the heart down. And this person had in the past stents. You see this kind of metallic white thing? These are stents. And the stents are covered with a material. Well, the person comes back with a chest pain, and we discover that we have this kind of bulge here. The cover of the stents, which is a material, broke. And then you form an aneurysm, which is a bulging. And if you don't treat that, it explodes, like all balloons. When a balloon starts inflating, at a certain point, busts. So this is a present form of CAT scan, which our radiologist friends love. And this is when they build it in 3D. That's what we do today. Then what we do, we superimpose what can we do to treat it. So to treat it, we superimpose a cover stent. This is the same kind of material that you see here, but has a membrane, and if you put it inside the previous stent, it stops the pressure on the wall of the artery, so the balloon has no more pressure, will not explode. And it gives us here on this side, with a special software, you stretch out the aorta and you calculate how far you have to deal with it, where do you cover it, and so on. So you see that's how it looks when you stretch it out and you see where this thing looks in a different dimension. And based on that, we calculate that we need just 20 centimeters of cover stent. You put it through a little hole in a groin, through a femoral artery. It takes about an hour and a half. You walk in, next day you walk out. This surgery, up till 15 years ago, you would be cracking the chest, doing a major surgery, stay in a hospital a week in a major pain. This is a walk-in, walk-out. It's almost like going to the dentist. So, this is a different type of patient where the patient was involved in a motor vehicle accident. And as you see here, the aorta had formed this kind of beak. And this is the same thing. If you don't treat it, it ruptures and you die probably in 2-3 minutes. So we do the same thing. We measure from where to where we have to cover it. based on this CAT scan, which was processed through 3D reformation, and they constructed this kind of model, and we know exactly how we're going to cover it. Now, if you have this aneurysm, which is no more in a chest, it's in a belly, it's called an abdominal aneurysm. An aneurysm is a balloon, basically. So you have this. Why it's so important to have this 3D view? Let me go back. Because based on this image, we know the type of curvature we have to take when we pass through a wire and how we calculate the lengths of how much we have to cover, what kind of diameters we have to use for these tubes we pass in, and which is the easiest way to go in. Well, like this side is very tortuous, it will be tougher. This one, it's easier. And another one of those, I'm not going to bore you much. Why it helps us so much is because you see this white thing, this is calcium. Calcium means that part of the wall, part of a pipe is pinched down. So you cannot pass a tube very easily. So you choose which way you're going to go in. Probably we're going to go this way in. So this is what is the present state of technology. Now, a new company comes out. It's called Centerline Medical. Says, okay, this is what you're looking when you work with. Radiation, gold standard, 4 million procedure done all over the world. Unfortunately, you have to struggle to see any wire, anything you do here, and you are exposing the patient of dye, because when you want to see the pipe, you have to inject dye. And every time you inject dye, it accumulates. There is a certain point after which the toxicity of dye is bad for the patient, and the radiation is bad for the patient and for the doctor. So they said, okay, let's do something different. So they are coming with this today technology. Unfortunately, it's not really today. It's still something for tomorrow, because not many places has this kind of technology. And they use an intraoperative positioning navigation. And how is this done? I'll show you after with what kind of machinery you have, but it really makes it look fantastically easy. So just to tell you about radiation, when we play with these X-ray machines, and our radiologist friends know, you got radiation to the eye, you got radiation to the body, but you have an apron, but many times the apron has a hole in it, and you don't know until you test them. It's a heavy armor. It's like you walk in an armor. And the vertebrae and all the spine takes a beating, and about a third of the people who work a lot with this have to retire early. So the doctors took a little bit of a beating from this. So this is, again, to the left, this is what we do today. This is nothing new. It's really the state of the art today. And that's why they want to go tomorrow. That's how you manage to enter and navigate through arteries using this technology. And how do you do that? Okay, first of all, you get a CTA. CTA is a CAT scan. And you do a CTA of very high quality. Then you input it in a computer which creates this kind of model. Then you put the patient on a special table, and I'll show you after that how the table is bent. You know, it's special attachment to the body. And then you do a cone beam CT scan, which superimposes to the previous one. Why? Because you want to be sure that any millimeter in my body, or the patient body in this case, corresponds to where you want to go. Because you don't want to put a wire in somebody and go somewhere in the brain. So, how they do that? They put under the patient a field generator, a special plate, and they attach to the patient this thing, which is also a tracking pad. So from that point on, everything in this computer, every movement, anything in it, it's communicated to the computer. Also, any wire you put, it's attached to a little sensor. And the sensor tells the machine where's the wire going. So, this other wire, and this is a sensor attached to each one of the wires. So they are not regular wires, they are specially designed for that. And this is the kind of images we see. When you do a long procedure and you have to enter some tough artery, and you do that only in the present technology, believe me, it takes a lot of time, radiation, and skill. This is for the best surgeons to enter these kind of things. If you have this image, it's much, much easier. Okay, let's go to something else. How do you deal with diseases of the aorta, where the aorta has a little hole or a little tear, or with pulmonary embolism? Pulmonary embolism means you have a blood clot, which was formed in the legs most of the time, and migrates, go into the lung. So when the lung gets a blood clot in a circulation, you cannot breathe. You breathe, but the oxygen is not exchanged. The size of the clot decides how fast you have to intervene and how fast the patient has to leave unless you don't intervene. So, usual, patient arrives to the emergency room. The emergency room sends to a doctor, emergency room doctor. It takes a little time. The man decides, okay, this is acute. I'm sorry. How do you get back? Okay, so by the time he is sending the CAT scan, it's about half an hour in the best of cases. From the CAT scan, they have to build the images. Then goes to the radiologist. The radiologist has to take some time. He has to read. There are several hundred images. Then back to the emergency room doctor, telling him, look, we found this kind of problem. Then the emergency room doctor decides what specialist to call. The specialist called, which is vascular surgeon, whoever they decide, cardiologist, he has to assemble a team based on what they find in a picture, get the right tubing, what to put in a patient. So that's a lot of time. And finally, treatment. So usually, this is the best hospitals. We don't talk about average centers which deal with this. It takes about 4 hours from the moment you get the CAT scan to the make of diagnosis. Then another 4 hours from the diagnosis to the treatment. And that's, if the patient is relatively stable. If the patient is not stable, you bring him to emergency room, you pray God, and you start cutting him open. So, how can it be done? You get this ambulance, you get the CAT scan, you send it to the cloud. In a cloud with a software, there is an artificial intelligence program. It selected the images. They know exactly what they're dealing with. And from that point on, the team which has all this software mounted on their phone, an iPhone, which all of us, we have an iPhone, it sends directly a message to the surgical team, and the surgical team alerts the OR team. So it's at minimum, this is, again, very advanced centers which have this software. It goes to 55 minutes instead of what you saw before. So how do they do it? Simply, again, I just visualize it. From the CAT scan, go directly to the cloud, where this software with the AI work together. They send a signal, because it's all programmed. You don't have to be intelligent to do it. It sends automatically a signal to the specialist. In the same time, the radiologists get the images. If the specialist is happy with the images he gets, because he gets the images on his phone, if he's happy, he gets to call his team. If he has any question, he calls a radiologist. But both are ready in the same time. You don't have to wait. So this is the kind of information you get, which is very important, because if you deal with a type B dissection, which means the pipe going from the heart down, this is vascular surgeons. If you deal with a type A dissection, which is from the heart up to the neck, cardiac surgeons get involved. So these are, in real life, very, very important decisions. They save a lot of time. So, and also for instance, here, it tells you, if you have a rupture, the time is is essence. Half an hour to an hour make life and death. So, how do they do that? Again, CAT scan, cloud. From the cloud, the software in 36 seconds, send it to the iPhones of the people involved, because you design a team which are ready. And not only that you have the images, but you also have the clinical data. 35-year-old from car accident, or 56 or 70-year-old with chest pain and so on. So immediately you have a clinical image, you have the pictures, you call your team. Just to show you here, it's very tough to read. That gives you a little clinical picture. It makes a diagnosis. It tells you what kind of problem you have. So you really, if you don't trust something, you can check. You have the images, you can check. But most of the time, everything is ready for you. You just have to act. Now for pulmonary embolus. So pulmonary embolus, clot is in a lung. Patient comes, usually short of breath, spits blood. He can barely, he looks pale. And you have to decide after you do a CAT scan if it's very severe, or you treat with oxygen and heparin, or you treat with intervention. So the same thing. Here it takes 63 seconds to come to this diagnosis for the artificial intelligence and AI. Sends a signal to the pulmonary specialist, to the cardiologist or vascular surgeon who is part of the team, sends all the clinical data, and they can call the team at the same time. The team can be on the same phone alert and go ahead and do it. You have not only that, but you have images which shows you the pathology, again, what kind of clinical signals and so on. Then you have something very interesting, which is it shows you the difference between right heart and left heart. And why is this important? Because it's called straining. If your right heart is under pressure because it pumps against a blood clot, the level of straining decides if you have to intervene or you just give him some medication. So see, this kind of measurements here is done. You don't have to see it and start calculating. It's coming directly as an image with data from the artificial intelligence imaging. So let's go to the stroke. This whole company started 5 years ago for stroke. That was their main objective. And then we talked to them once, and I said, you know, I would love to have this in vascular surgery. So it's not very difficult for them to adapt it. By the way, my discussion with them was pro bono, was friendly, no compensation. So they look at stroke and they immediately come with images which tell you it's a large vessel occlusion, intracerebral bleeding, or an aneurysm. So you have all this. You can decide what you want to put in images. You can have CTs, you can have MRI, whatever you want comes under this kind of pictures to the team, group of doctors which are involved. So you have the clinical information, you have the pictures, and you have to go then and take some action. The sad story is, and that we're talking United States, the best hospitals, okay? About 10% of the strokes are treated with either TPA or neuroradiology where they remove the stroke. So the waiting time is 3 to 5 hours before the emergency room, the decision making, the CT scan, and so on. So it's a big problem because the stroke window is maximum 6 hours. Earlier, the better. If you want to walk out without walking like this, you better have something done fast. And why the same thing? They come in, they cut the scan, manual. It takes over 2 hours. And that's the best places. So here it tells you, patients who are brought to hospitals who don't have a neuroradiologist and need intervention end up being about 5.2 hours. Places like universities, like we talked, they have a much shorter time, but still it's 3.2 hours, which is not so great. How they do it? The same story. They take the images immediately to the cloud. From the cloud, they send every person involved in a team of stroke response. So everybody gets the same images, everybody gets the same clinical picture, and everybody can make rapidly a decision. They don't have to communicate linear one to other. So if you look at the time saved, door to door, if a place which doesn't have radiology, With this kind of software, it's about an hour and a half. They save, based on the standard of care. Standard of care is based on all hospitals, everywhere. Based on standard of care, they save you immediately about an hour. Now, if you have neuroradiology in-house, from the moment you enter to the moment you get puncture in a system with this software, it's about an hour and a half instead of 3 hours and a half. So that really improves the... So if you look, a number of times, the quantity of time saved, 73% from the CAT scan to the team which was alerted, and the time from the team alert to the intervention, another 24% saving. So there are studies which show you have 44% more treatment, days in hospital less, the scales, they have special scales for stroke which are so much more improved. So clearly there is a need to kind of implement that. There are about 1,200 hospitals in the United States which have this software, but it's only 1,200 and we have much more. Okay. And the last one, I'm trying to make it fast because it's the end of the day and everybody's tired and sleepy. The last one is something about what do we do to improve surgery outcome? What do we do to make the surgeons better? And this company, Theator, came out with some ideas. So when you do, this is a gallbladder or gallbladder. When you take out a gallbladder, you take it through these little holes. That's why it's called endoscopy. And when you dissect using several instruments, we are human. We make mistakes. Something can be, or a patient has very difficult anatomy or a very advanced disease, you can get into trouble. And complications occur. So there are about 10 million minimally invasive done every year, all over the world. So we're talking huge numbers. It's not something small. What could you do to get these images, to analyze them, find out where you make mistake, and try to avoid this mistake, or try to see how can you improve. So they get all this data. While you do the operation, and you watch on the screen, the same images go into the memory in a cloud. All is done, and then you can have them, the way you set the system, delivered to your phone, iPad, whatever you choose. Also, you have privacy. In other words, the system puts a little box that takes away the name of the patient, the name of the surgeon, anything which could connect, so it keeps privacy. So let's say you cut some adhesions, you got an event, you cut down the cystic duct by mistake, it happens. What do you do to fix it? And then how do you make decisions how to treat it? And this goes for several fields, urology, gynecology, general surgery. These are the people who use endoscopy. And then you take your data, the machine prepares you don't have to be working hard, and you compare your data, you are blue, and the rest of your team, hospital you work in, is this color, purple. And you compare everything you've done, and you see, when I take out the appendix, I take double the time of the other guys. So maybe I learned some things here. What can I do to improve it? And you'll find out solutions. Then you take, by procedure, everything you've done, and they compare averages. So based on that, you can decide, okay, I'm more or less like everybody, or I can do something to learn something to improve. And for teaching purpose, this is really the great thing. For teaching purpose, for instance, you have to take out some lymph nodes. Here it's explained step by step, based on this. They have many procedures, so they select the images they want. What do you do? First you do this, then you do that. So every little step can be recorded, so you can show a resident, you can show another doctor how this is done. This is ratio space. It's a space in front of a bladder. When you work in this area, how do you do it? These are tough operations to learn, and it's very easy when you have a visual. A visual is better than 1,000 words, believe me. You want to start anatomically explained, it's 10,000 things. You see what you're doing, it's much easier. Then you take all this data and you show the people, you show them, look, this is the simplest way to do it. Let's not go around and do things which really you waste time and you increase the risk of complication. So you create a very good practice for everybody. Then you kind of standardize, if you can, if you have people who are collaborating with you. You show the OR staff the instruments that they should have in each standard procedure. You don't have to say, oh, I need this instrument, and they start looking for it because they don't know what you're talking about. And you can improve the outcome of the patients, but you also improve the patient's treatment per case. Then you compare to other surgeons, compare to other places. Like, let's say that university is very advanced in this kind of procedure. How they do it with how we do it. So you improve really without any major effort, because you don't have to put the name of the patient, the name of the doctor. You say, look, this, I think it's a good technique. Let's apply it. And all these together, it's a teaching instrument. It's also an instrument which you can use just in average hospital where you don't even have residents, but you have a conference and you look at your complications and you don't understand what happened and why, and you don't see, because person says, oh, I remember that. You have the images, you don't have to remember. So the first is capture information. Then you see how it's done step by step. Then you compare your data. What can you do to help during the procedure? Not only analyze after, but during, can you do something to make it safer? So here comes, let's say the same group of doctors put somebody in standby. Any specialist who's very good, who has a lot of experience doing procedure, and they are in standby. You get into trouble, you push the button, that person is immediately ready to give you an advice. You have advice in a tough moment, you save a life, or you save a complication, which is major.